Hi class, welcome again to another session on rehabilitation engineering. So let us now discuss pathological gait. Now pathology means abnormality, right? So there are gait or walking style which are not normal. Like every individual has their own style of walking, but abnormality means you know like uneven distribution of force from one side to the other side, and then you know not walking properly, like putting more pressure on your toes than on your heel or so on. The pathological gait can occur as a result of neurological or orthopedic condition, which in turn might result in pain, loss of muscle power, increase or fluctuating muscle tone, incoordination of the muscles, and skeletal deformities. So all these are responsible for your gait to become abnormal. So there's a picture here which says spastic gait, which is generally observed in stroke patients; propulsive gait, which is usually observed in people with Parkinson's; and then high steppage gait. So let us discuss more pathological gait. So mainly you have Parkinsonian gait, where it is, like the name suggests, is seen in people with Parkinson's disease. So these patients are affected by rigidity, reduced speed, and stooped posture. So the cadence, that is the number of steps per minute, is high in these patients, and they appear as if they're trying to catch up their steps. So their stride length is really small. So they're trying to run and chase their own selves. It looks like that. So these people, they lack toe off, heel strike, and diminished arm swing as well. So they are more prone to tripping, and falling as well. So in order to reduce the number of falls, these people, they are asked to wear modified footwear, and some of them, they receive electrical stimulation to facilitate better foot lift. Another pathological gait is scissoring gait. So the characteristic gait of a spastic person, and it is a result of bilateral adductor spasm of the hip and then the equinus contracture of the ankle. The patient usually is leaning forwards and outwards and clears the ground only when corresponding shoulder and knee is risen and the body is tilted on the opposite side. So it sounds like very, very uncomfortable. So your body, so that if you are putting your right foot, if you're trying to lift and plant your right foot, then your body is twisted towards the left. The right shoulder and the knee has to raise in order to facilitate ground clearance. So the risen knee is brought forward, and when it comes in contact with the other knee, and the hip pivots the pelvis, and the individual walks with their toes due to spastic Achilles tendon. So I have a picture here. So the picture on the right, let me just take a pointer. So this one here is a scissoring gait. You can see that the knees are together and the arms are wide apart. So this is a very uncomfortable position, and usually, like in clinics, I've observed children with cerebral palsy walk with scissoring gait, and they usually walk with their toes. They do not plant their heel at all. And the the left one here is a Parkinsonian gait. You can see the person stooping, and the arm is like not swinging at all while walking, and the foot lift is not very good, and then the heel strike, toe off is not very good either. So they have shuffled steps, and they're quite rigid, and there's asymmetric resting tremor as well. So this is like typical Parkinsonian gait, and they're very slow movement as well. So other than these, you have the ataxic gait. We discussed ataxia, which is the lesion of the cerebellum or the posterior spinal cord. So this gait is present in people with cerebellar diseases, disseminated sclerosis, or cerebellar ataxia. Some patients cannot rely only on the proprioceptive feedback, and they often look around for visual cues as well, because they just not confident enough with the feedback that they're getting through their proprioceptors. So generally, this is a very bad example, but it was given in your textbook. So they usually walk like a drunk person would walk, and then they have the tendency to swing from one side to the other, and it's uncontrolled. It's not because they're drunk or intoxicated, it's because they have a disorder which is making them walk like that. And their step and stride length are unpredictable and uneven. You just can't say that it's going to be this much of stride length or anything. So it's just unpredictable. It's good at some times and it's very bad at the other. So there are types of ataxic gait. You have the sensory ataxia or ataxic gait, which has very limited sensory cues. They lift their feet high and stomp it in the ground, heel first. So, and they walk with feet wide apart, and they are noted, and it is very very commonly noted in people with Chavis dorsalis. And then again, the next one is the waddling gait, where the person walks pretty much like a duck. Their feet are wide apart and they increase the base support to the plantar flex due to shortening of the calf muscle. And this type of gait is commonly seen in women in the late pregnancy and osteoarthritis people. And then you have the high stepping gait, which is also called the drop foot, where the patient is not able to clear the ground during the swing phase. And this occurs due to neurological disorders. People with Parkinson's, cerebral palsy, or stroke end up with drop foot, and they either need stimulation on their tibialis anterior or popliteal fossa to make sure that the foot is lifted high enough for them to clear it. And then the hand to knee gait, which is observed in people with poliomyelitis, and because their quads on the affected side is paralyzed, and it doesn't support walking very well, so they have to put their hand in the knee in order to support and facilitate walking. And then you have the gluteus maximus gait, where people with paralyzed gluteus maximus often throw their head backwards in order to support their balance while planting their foot. So it is a very weird, and it also looks like an English lord walking. So that's just how it is. If you have paralyzed gluteus maximus, then your gait gets affected. And then you have the antalgic gait, where the gait of the person in pain, because imagine anyone who's had an ankle sprain, or a knee problem, cruciate ligament problem or something. So every time that if you plant your foot firmly in the ground, then you're going to experience pain. So we just try to alter the weight balance such that the good leg is actually taking up most of the body weight, and the injured leg is being pampered. And on doing so, you're like putting double the load on the good leg, and ultimately that wears off as well. So it has to be, it is something that needs attention, because otherwise the good leg will also get injured, and then the person would have issues walking. And then you have the hip hiking gait, where the entire foot leg is lifted and planted in the ground. So usually this is observed in people with restricted knee mobility. For example, someone has had a plaster of Paris cast in their knee for a very long duration, a couple of months or so. So when the cast is removed, the knee is still very very rigid, and it's not flexible enough for facilitating flexion. So that would result in the person lifting the entire leg and planting it on the ground, and that is the hip hiking gait. And then you have the hemiplegic gait, which is commonly observed in stroke patients. So these patients usually circumduct their hip and plant their foot to while walking, and this is because of spastic knees and calf muscle. Last one is the bear walk, which is a modified crawling basically, because crawling people think it is It doesn't. Many people do not like crawling. They just feel their egos hurt slightly, so they try to walk on 4 foot, all four limbs, without their knees planting in the ground. So it is like walking in plank position. So that is called the bear walking gait, and all these are results of ataxia. I hope you had a very fruitful session learning about pathological gait with me. I shall see you again in another video. I hope you take care till then.